So welcome to this symposium on SMT from RCTs to real world. I'm Shripal Bangalore, interventional cardiologist at NYU Langone Medical Center in New York, New York. I'm joined by an esteemed group of people.
Professor Patrick Serreus. I'm established professor in medical intervention and innovation, and I'm located in Galway, University of Galway in Ireland.
Welcome.
Hello, David Leistner. I'm professor for cardiology as well, and I'm the head of the Department of Cardiology at the University Hospital of Frankfurt in Germany, and also interventional cardiologist for now more than 20 years.
Welcome. So today we're going to discuss about ultra-thin Supraflex stents, and there are a number of exciting trials. Some of them are being presented here at TCT. Maybe let me kick off, Dr. Serreus. So you're going to present the multi-vessel talent. Can you tell us about the design of the trial and what are the objectives?
Yeah, so it is, of course, a randomization between two stents. I mean, the Supraflex and the Synergy, and we can talk a little bit about the technology of the Supraflex. But what is important is that we have tried to apply what we call the best practice of the state of the heart. What does it mean? It means that in every patient, we do QFR, so we do physiology derived from angiography, and then define which lesion has to be treated and which lesion has to be deferred. And the criteria is 0.80. That's the first component. The second component, you have to do IVUS and OCT after the procedure. You can do before, but after the procedure and reach some criteria, 4.5 millimeters square for the IVUS, 4.5 millimeter for the OCT, and 5.5 for the IVUS. And then the third component is, after the IVUS and the OCT, is that we have an expert on CTO accredited by the investigator site, which will take care of the CTO, which was seen in 1/4 of the patient. And finally, we have monotherapy with prasugrel. So after 1 month of the APT, we stop. And then all this film came to the core lab by telemedicine. And within 1 or 2 hours, we were sending to the investigator all the delta QFR and the diameter stenosis. And the core lab was doing that. The informed consent has been obtained. Therefore, the film could come to the core lab. But there was prior to randomization. We didn't know what was. So that's the kind of best practice that we had. And as you know, Synergy is well known, but what is specific for the Supraflex Cruz is this long connector going from valley to valley, which give an element of flexibility and pushability. That's basically the idea. And then we use the data of Syntax 2, which was not randomized. That was a propensity study versus surgery. But in Syntax 2, we went FFR and IFR in every lesion, also three-vessel disease without left main. I forgot to say that in the first place. And then also using IVUS. And in that trial, at 1 year, we had about 10.7% of event. So that was basically our even rate to calculate the margin of non-inferiority and go for a non-inferiority. Basically, the first year, it's a non-inferiority on what I call POCHE, patient-oriented composite endpoint. The second year, we will look at VOCE, and then we are aiming eventually to superiority. That's basically the whole trial.
So that's fantastic. So just to summarize, multi-vessel talent, patients with multi-vessel coronary disease, and optimized in terms of PCI, and optimized in terms of antiplatelet. And we'll hear soon from you, does it matter the difference between stents? And just to, for our audience who don't know Supraflex is an ultra-thin platform. It's a 60 micron stent thickness, whereas Synergy is around 74 microns. Okay, Professor Leicester, so you're leading the Senior Cruz trial. Can you tell us more about it? Who are the patients and what was the design of the study?
Right. So Cruz Senior addresses a question, I think, which will be the most important or one of the most important questions in interventional cardiologists for the next 20 years. This is a question how you want to treat aged patients. So we focused in Cruz Senior on octogenarians and nonagenarians, so patients older than 18. Cruz Senior is a prospective registry, a pragmatic registry, so an all-comer registry, all patients that come to a hospital with chronic coronary syndrome and acute coronary syndrome without the group of the ST elevation myocardial infarction. These patients were included in this registry. It's a pan-European registry done in France, in Germany, as well as in Switzerland and in Austria. So we have nearly 40 different study sites. And the special thing of this registry was not only to look for clinical endpoints, as we know this from stent registry, in this special high-risk patient cohort. In addition, we assessed very, very clearly the quality of life. I think this is the most important endpoint in this aged patient cohort. And this is unique, and this is why Cruz Senior is a very, very special, unique, and very pragmatic trial. We also evaluated the individual frailty of this aged patient with different tests. So now we are able to see which grade of frailty leads to which clinical outcome, so we can combine the special situation of the patient with the outcome following PCI. So just a registry, but a registry, I think the first prospective registry with such a large patient cohort, nearly 2,000 octo and nonagenarian patients. So this is the innovative part in the study.
Yeah, no, absolutely. I think just to summarize, you guys are testing a group of patients which are excluded from randomized trials, right? I mean, we don't see a lot of 80 and 90 years old, and I think that will be a very important study.
So it's my turn to ask a question. I mean, because Pendra Kaul from India will present the Tuxedo 2. Tuxedo 1 was in the New England, and you are there to talk about the Tuxedo 2. So what is the trial?
Yeah, taking along the lines of what you guys just talked about, in Tuxedo 2, I'm the co-chair of the trial. We are taking patients with diabetes and multivessel coronary disease. And the way we designed this was to mimic the inclusion criteria of the FREEDOM trial. I mean, the FREEDOM trial was diabetes, multivessel disease, randomized to PCI versus CABG. So we took the same inclusion criteria, but here we're taking diabetes, multivessel disease, and randomizing them into an ultra-thin Supraflex or a Science platform. And there are some synergies between the multi-talent trial in the sense that we are trying to maximize optimal PCI. We are also trying to maximize the medical therapy. So it's antiplatelet, lipid-lowering therapy. We have a goal of less than 70 and preferably less than 50 in terms of their LDL cholesterol goals. We have a stringent goal for their HbA1c and also for blood pressure control. And that one is for a one-year endpoint. And the primary endpoint is target lesion failure. And it's designed as a non-inferiority trial to show that Supraflex is non-inferior to the Science platform.
Very good. One question, are you using the hemoglobin A1c to see the quality of the treatment in these patients?
Yeah, absolutely. And, just like FREEDOM and other trials, we have been following this. I mean, we are reaching out to sites to make sure they maximize the medication. So some of the medical therapy goals are hemoglobin A1c of less than 7. Interestingly, in the trial, 81% of them achieved the hemoglobin A1c of less than 7. LDL cholesterol goal less than 70 was achieved in 80%. Less than 50 was achieved in 42% of patients. And systolic blood pressure of less than 130 was achieved in around 67% of patients. So the question was, if we optimize the background medical therapy, is there a difference in stents? I think we are all talking about trials that likely is additive to the literature and adds to it. So maybe let me start with you, multivessel talent. Can you give us a sense of...
Multivessel talent, I have to say something, is that I told you the film come from the site to the core lab. And basically, the patient has been selected by eyeball, three-vessel eyeball. I see in the three-vessel something which is more than 50% of around 50%. And then in the core lab, we did this huge work in 9,961 lesions to do the delta QFR and the diameter stenosis. And then what happens is that basically 67% of the lesion had to be treated, but 33 should not be treated, could be deferred. That's very important. Now, that was a huge enterprise because you realize we sent within 1 or 2 hours basically a slide deck of 6 to 10 PPTX slide deck. So that 8,000 slide by telemedicine. And then what we see is that many of these three-vessel eyeball were reduced to one-vessel disease, two-vessel disease, and finally three-vessel disease. The number for reducing to one vessel and deferring two was 17%, okay? Then there is a second group with two vessels treated and one deferred, okay, that was 44. And then finally, the three vessel have lesion flow limiting in all three vessel, and we treat the three vessel, that was 36 in both arms. So that's very important to see that between the eyeball and the quantitative measurement, you can reduce the amount of stent. This is a difficult population because the syntax score is 20 anatomic. The upper quartile is 26, so they are 26 above. And I have to tell you that we did not make any exclusion on syntax score like in the guideline. So we asked the heart team to take the decision. So we had a 10% of more than 33, which is in red in the guideline, but we did. And I will tell you something about later. In terms of patient, you have heard one vessel, two vessel, three vessel. There is 1/4 of CTO, and then 3/4 of the patient have bifurcation. So there's a lot of disease to be treated. And the QFR of the vessel in general was 0.67. And we bring back that to 0.95 after the procedure. So that's what I can say about the patient recruit in this trial.
That's fascinating, and kind of, first of all, it sounds real world, and clearly real world discordance between what eyeball angiography and QFR can do, and reclassification of those patients. So that's very intriguing. Can you give us a quick sense of what was the sample size?
The sample size was 1,550. That's based on the even rate of syntax 2, which was 10.6. And that gave us a margin of non-inferiority of 4.6, 1.4 of the numbers. So that was the target. I mean, a non-inferiority with a margin of non-inferiority of 4.6%,
Okay, I'm sure everybody is waiting for the primary endpoint result. So can you give us a sense of the primary endpoint result, and then we'll go to Cruz Senior, and then we'll come back to you for the subgroups if there are any important.
Right. So what happens is that we achieve the non-inferiority, so everybody is happy. The number of composite event in the Supraflex was 15.3 and 14.7. So the difference is 0.73%, less than 1% difference. And the margin of non-inferiority was 4.28, and the 95% confidence interval bring you to 3.73. So the p-value was 0.026. So we achieve inferiority. Now, what is interesting is that we used the SKY definition in that trial, and the composite endpoint observed, not assumed, but observed, was 14.6, so a little bit higher. So we used the same rule of non-inferiority, but then you have a p-value which is 0.0001, okay? So that's interesting. We are very happy with this result. I must say that there are a lot of sensitivity analysis because the SKY is basically an enzymatic criteria. Originally in the JAC 2013, that was 5 CKMB plus a Q wave, then it's a peri-procedural, of 10 CKMB, and then it's a peri-procedural. But of course, as I said, there is the noble approach where you eliminate completely the peri-procedural, maybe not a bad decision. Then you have the old syntax 1, you have ARC2, and then finally you have the universal definition. And you see that these peri-procedural MI is really a confounding factors because I would not say manipulate, that's the wrong word, but you can have different approach. And we did that as sensitivity analysis. I will come back on the subgroup later.
So, great insight on the results. So Supraflex, non-inferior to Synergy.
Yeah.
Okay. So let's go to Cruz Senior. Can you give us an insight into number of patients and some of the results?
So we included 2,000 aged patients. And I think this is what we expected. The patients were very, very sick. They had at least 3 very, very severe comorbidities. Just to give you some numbers, we had about 10% of the patient had a stroke before, within the year before they were included. We had about 30% that are on atrial fibrillation. We have 35% on oral anticoagulation therapy. We have nearly 60% with renal insufficiency, acute or chronic. So you see a very, very sick patient cohort. And what we, in the beginning, when we talked about the trial, we were very afraid that this could lead to a less rate of follow-up, to loss of follow-up, something like that. This was not the case. We really have a follow-up of 98% of this patient. I think this is a great success. First result, and this is a bit that shows the potential of the Cruz Supraflex, especially in this very, very complex aged patient cohort, we had a device success of 99%. I think this is really great, given the fact that 1/3 of these patients had very complex coronary lesion. This includes bifurcation treated with 2 stents, leads a lesion longer than 28 millimeters. So we used the same definition that was used in other similar trials before, especially the Ultimaster trial. They used the same, and we had a higher number of this complex lesions. So we have a very high rate of device success in a very, very sick, very, very complex patient cohort. And I think this is a great result, not only for the patients, also for the Supraflex Cruz, because this seemed to be the perfect coronary device for such a high-risk patient cohort. Second, and I think this is also interesting, we see what is the feeling of sickness, what is the quality of life of this very aged patient. And the patients really suffer from their coronary artery disease. So they had low quality of life. They have a high angina burden. More than half of the patients had more than 3 times a day angina. So there was a good indication to treat them. And this is one of the other results that we saw within the first months after the procedure, this angina relief goes down. And so they had a significant improvement of the quality of life. So this is another finding. Treat this very, very complex patient by PCI, you improve their quality of life. And I think this is important for this cohort of patients. It's not important to reduce the rate of all-cause mortality within 10 years if you're 90 or something like that. It's important to prove the all-day clinical or the all-day quality of life, and this could be demonstrated with this Cruz Senior. And I think this is the most important thing with respect also to the device-orientated clinical endpoint. We have an interesting finding, except for the endpoint cardiac mortality. It's clear that it's higher than in a patient cohort that is 20 years younger. But all the other endpoints, myocardial infarction related to the device, target lesion failure related to the device, it's lower than it was observed in the TALENT trial. The TALENT trial, the mean age was 66 or 67. We have 82. So that makes clear the potential of this Cruz Supraflex, especially in this high-risk patient cohort, to treat them safe, to treat them effective, and to improve the quality of life of these patients.
So great findings. So just to summarize, 80 to 90-year-olds, and 2,000 of them, most of them HBR category, high bleeding risk. So you want a platform where you're not only successful, but make sure that your dual antiplatelet therapy, maybe we'll come back to that later, but you don't have to prolong it. And you also want a platform where there is no increased risk of stent thrombosis or stent-related events. So it looks like patient did fantastic from symptom and clinical standpoint.
No, we are on the edge of our seat for your result this time.
Yeah. So, going back to Tuxedo 2, we randomized 1,800 patients, all of them diabetes, multi-vessel disease. And the important component was we capped patients with two vessel disease to around 15%. So we said, there is a tendency for, people to enroll less sick patients. So we wanted a lot of triple vessel disease based on freedom. So once the double vessel was capped, they were only forced to enroll only triple vessel disease. So at the end of it, 1,800 patients, diabetes, 85% were having triple vessel disease. Randomized to Supraflex versus Xience. The primary endpoint was target lesion failure. At end of 1 year, Supraflex met the non-inferiority margin for target lesion failure. Interestingly enough, this was true. If you look at all the individual components, cardiac death, ischemia-driven, target vessel myocardial infarction, and ischemia-driven target lesion revascularization. No difference between the two groups. Interestingly, what we found was if you look at the non-fatal MI, numerically lower non-fatal MI with Supraflex platform compared to the Xience platform. It did not reach statistical significance. But interestingly, if you look at meta-analysis of all of the ultra-thin platforms, there is a signal that there may be a potential reduction in TVR and MI, and this is very consistent. But I want to point out that it was not statistically significant. The p-value was 0.1, and in a sensitivity analysis, it was slightly even less than that. But that's where we are.
Very interesting.
And so maybe let me turn to you guys again. Those are the primary results.
Yeah.
We know with any clinical trials, there is much more than primary. I'm sure your group, knowing what you do, there must be a lot more to it.
Yeah.
Is there some important things that should be a take home?
I think the two salient features is I told you about the sensitivity analysis. So at some point I said, okay, in the sensitivity analysis, and it will be in the manuscript, let's take the noble approach. The noble was this bypass surgery versus PCI, and they eliminate the peri-procedural from the equation from the composite endpoint. And then we had a surprise to see that the composite endpoint, POCHE, all deaths, all stroke, any myocardial infarction, any revascularization, the most global thing that you can think about. You don't need basically adjudication for all death. That's it. That was interesting because it became 9.2 for the Supraflex and 9.7 for the Synergy. So the good news that in three-vessel disease, carefully analyzed from the physiological point of view, we are below 10% composite endpoint, the rough one, in that kind of trial. But the two conditions is that you select the patient, that you have a good art team to say, okay, that syntax score more than 33, for some reason you can do it, the surgeon. And the number of heart team percentage, the rate was very high, was in the 98%. So almost everybody can carefully to this heart team. That's one thing. The second thing I told you, we did not eliminate the syntax 3. We did not eliminate the syntax 2 above 22, we did not eliminate the diabetic, even the insulino-dependent. So we look at that, and then we have the surprise to see that in the syntax more than 33, suddenly the two curves diverge quite numerically, quite importantly. It's 22.8 for the synergy, and it's 14.6 for the Supraflex. So that's really, I would not make a big case of it because it's about 10% of the patients. So it's a cohort globally of 151 patients. But it's an interesting signal. I mean, pushability, flexibility, and all these kind of things. So that's maybe that we have to investigate. Another point is that we were excluding left main, but of course, there's always a few protocol violations. But what is much more interesting is that every time you could take an ostium of the LAD, you could take an ostium of the circumflex. You cannot do both because that's an equivalent of left main. But then the stent is always finishing in the main stem with a pot. LAD main stem pot, circumflex main stem pot. So that's a cord that we still have to review in detail, but that will be interesting. So in summary, of course, the major title is non-inferiority of the Supraflex versus synergy. But I think the two important point is that physician has to be careful when they say it's a three-vessel disease and put a lot of stent in these patients. I think you need that physiology. In this case, we did centrally, but in the next trial, it's again back in the end of the clinician. They need more and more education on the QFR because it's not something which is done. You need a very good acquisition. So I think it's important. And then the safety signal, you have a three-vessel disease, you go to whole scale of a syntax score, post-approval by the heart team, and you get below 10%. It's quite encouraging.
Yeah, I think those are amazing results, I must say. And I think it's a win for the patient. So you now have option. Supraflex is as good as synergy, maybe a signal in the high syntax group, which needs to be tested, but that's an interesting signal. Maybe we'll come back to that. Maybe I want a quick comment from you, whether it's play of chance or maybe it's hypothesis generating, if you're taking that to the next level. But let's go back there. Is there any other results that you think it's significant? Specifically, I'm curious about nanogenarians. I mean, I don't know if the study has as yet analyzed it, because I can tell you, when I see my 90-year-olds in the hospital, I try to be as conservative, like we stent and get out and like not try to do anything fancy for them, wow. So how did those patients do?
So first of all, the nonagenarians have the same benefit with respect to the quality of life as the octogenarians. So it's the first point. It's clear that they have higher endpoints for everything, especially for mortality. It's clear that it's another 91-year-old woman other than in an 80-year-old woman. But the important point is another one. We checked in the Cruz Senior for the first time, we used the PROMS, the patient-reported outcome measurement, which is, I think, a very, very innovative tool to test the individual quality of life and the individual improvement by any medical therapy or medical measurement. And what we see is if you calculate the delta of the PROMS over the beginning, so when the patient gets the stent and 4 months later, you see a significant improvement in nearly every patient, octo as well as nonagenarian. But now, and this is important, the most frail patient have the most benefit in the quality of life if you do PCI. This means what you showed in the beginning from your clinical routine, that we have to prove us all that it's not anymore true that we should decide which patient should underwent PCI and what patient should not underwent PCI. It's independent from that. Also, the frailest patient have clinical and individual benefit by doing PCI. So we have to prove ourselves. It remains to another question, how can we decide what patient should treat it interventional and what patient should be treated conservative by medical therapy? And we have some very innovative part in the Cruz Senior study, which is not analyzed yet. We measured the individual biological age by a special biological age reader in this patient. Then you get a threshold of the patient. And what we actually analyze whether this threshold can be the threshold to decide for patients that have most benefit from interventional procedure and what group of patients has benefit from conservative treatment, because this is independent from your individual feeling, your individual being. So this is another very interesting investigation that is actually analyzed.
Yeah, so I think just to summarize, I think very important findings. The 90-year-olds get as much benefit in terms of quality of life with PCI as the 80-year-olds. Frailty, I mean, one of the big concerns, I must point out, frailty is more of a concern in the surgical world, but many a times we tend to use that in the PCI. At least now we should say, look, I mean, yeah, frailty does matter, but doesn't mean you have to be as conservative in terms of PCI, at least. Okay. I know in the interest of time, I'm just going to summarize Tuxedo 2 in terms of subgroup analysis. Interestingly, just like as you showed in the multivessel talent, we did do a subgroup based on syntax score. We did have patients with syntax over 33, a small proportion of patients. There was no treatment interaction. So in all subgroups, there was no difference between Supraflex and Xience. It did behave very well, whether it's small vessel disease, insulin dependent versus non-insulin dependent, age, and so forth. So there was consistency of that.
Very good. Time is over.
So time is over.
I think we said what we have to say.
Yeah. So just to summarize, I think this is fascinating. And so we talked about Supraflex and ultra-thin platform in comparison, one with Xience, one with Synergy, and real-world evidence in the octogenarian. I think this data will be very useful clinically.
Absolutely.
And I'll leave the last words to you.
No, I think we are always pushing the boundaries. One trial call another trial. I mean, you said maybe we should explore the more than 33 and the mainstem. We'll see. But one thing, the final word, we still have to work very, very hard on the secondary prevention.
Yeah.
I mean, it's amazing to see that only 15% of the patient have a cholesterol below the guideline, so we have to work. But it sounds good in general.
Yeah.
Thank you very much.
Thank you. Thank you for your attention.